Thank you very much, Ian. With an introduction like this, you can only be disappointed now by my lecture. I want to thank, obviously, the Review Committee of CON for allowing me to receive this award, but I will not accept this award as an individual. Let me accept this award on behalf of outstanding colleagues and mentors with whom I've had the privilege of working for more than 30 years now, and I'm thinking, I won't name all of them because I'll be naming them for 30 minutes. I will use the time allocated for my talk. But Claude Bouchard, Angelo Tremblay, you heard, they were really important colleagues in the early stage of my career. And now for the last decade, Dr. Denis Guichard has been an outstanding colleague. I am blessed with a network of outstanding local collaborators at Université Laval and Quebec Heart and Lung Institute, as well as wonderful international friends, collaborators, and I'm very grateful to them. As Ian pointed out, this is very dear to my heart, actually. I've been blessed with outstanding graduate students that have enriched my life and enriched my personal life on top of my professional life. So I'd like to receive this award on their behalf. You know, they're really part of the story, this outstanding group. Now, those are my disclosure, just showing you my relationship with the industry. But let me now take a minute of your time to show you my #1 conflict of interest, because it's very, very relevant to this talk. This is my #1 conflict of interest. This is my colleague, previous graduate student, Dr. Isabelle Lemieux, who has a very large waistline on this slide here, and I'm responsible for that large waistline. And those are the outcomes. They have enriched my personal life tremendously. And as I was blessed with two beautiful adult children, I have to tell you that I'm a very, 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 very lucky person, period. Now, enough of my personal life, which might be boring to you, and let's move on to the topic of the lecture tonight. You know, over the last couple of decades, I've been involved in many, many debates about whether or not we have an epidemic of obesity because we eat too much or we spend less calories. And to a certain extent, this is interesting from an academic standpoint, but pretty useless as a public health message, because of course it's a combination of both, and the relative weight is going to vary from one individual to the other. It does not take a rocket scientist to figure out that our daily energy expenditure has decreased by several hundred calories per day while we are exposed to this energy-dense food, and some of us can resist to this offer, some of us cannot resist to this offer. I got to tell you, I'm having a very hard time to resist to this offer, and I'm not the only one. And I often say in my lay lectures to individuals in the room, well, you think that it's difficult to maintain your body weight? You're a normal person. It's the norm now to be overweight or obese in North America. It's 75% of the population who are overweight and obese. You know, what is really peculiar is to be able to maintain a normal body weight when you are sedentary. And I'm a perfect example. I'm sitting 60 hours a week being sedentary. So if I don't force myself into doing something pleasant, physical activity, I'll be very, very vulnerable to an environmental offer where we have plenty of access to energy-dense food. And we need to keep in mind that there's a reason for this. Well, thousands of years ago, there was still a survival advantage to be able to put a little bit of energy in the gas tank. Those of us who were not able to do that, well, they would die, they would starve. As a consequence, obviously, this prevalence of overweight obesity wouldn't be an issue if it was only cosmetic. The problem is that obviously there are medical consequences, and one that you know very, very well is type 2 diabetes, and many of you have seen various versions of the slide in the past showing you the expected progression in the prevalence of type 2 diabetes worldwide. We know in the United States about 25 million individuals, in Canada 2.5 million, but there are some part of the world where there's a stunning increase in the prevalence of type 2 diabetes. Ian was kind enough to refer to the International Chair of Cardiometabolic Risk. We organized a meeting on nutrigenomic and metabolic health in Shanghai with the Harvard School of Public Health last October, and there was a representative from the Department of Public Health of the government of China who presented us the stunning figure. There are now 100 million diabetic patients in China. 100 million. Now, in cardiovascular medicine, however, we have done a pretty good job at identifying, I would say, the ABCs, the drivers of cardiovascular disease risk. And fortunately, we have emphasized the hazard of smoking. We have now drugs, powerful drugs to lower cholesterol and blood pressure. Yes, our patients are eating less saturated fat, and they try to decrease the salt content of the diet, but make no mistake about it, the bulk of the reduction in cholesterol and blood pressure is due to the fact that now that we have powerful drugs to lower cholesterol and hypertension. But those medical progress could be offset to a certain extent by now the consequences of this environment that we have engineered for ourselves. And in a very elegant editorial published in the JACC last year, Darius Mirzafarian from Harvard suggested that the way we prevent cardiovascular disease death is inefficient and costly because we use downstream procedure and multiple drug approaches, and that population shifts that we just highlight grossly undermine our effort. And actually, when they examine and they set up their goal for 2020, the American Heart Association actually has made what I consider a quiet revolution, shifting from cardiovascular disease to cardiovascular health. They wanted to reduce cardiovascular disease by 20% by 2020, but also improve cardiovascular health, which is really a conceptual shift. And to do that, well, you're very familiar with secondary prevention, prevent a recurrent event in someone who had an MI, for instance, or primary prevention, primary care doctor, when he sees elevated cholesterol, hypertension, is going to treat with drugs to reduce the risk of a first event. But they raise the bar, emphasizing that the key objective should be primordial prevention, avoidance of the development of adverse level of CVD risk factors. Now, to introduce that concept of ideal cardiovascular health on the basis of the science available, they identified what they call the metrics, the simple 7 metrics defining ideal cardiovascular health. Now, here you recognize the well-established biological risk factors, cholesterol, blood pressure, diabetes, but on the basis of the evidence available, they also introduced the health behaviors. Non-smoking, obviously, is an obvious one. They use a body mass index below 25. They discussed whether or not they could use waist circumference, but since that variable was lacking in a lot of large database, they proposed to use BMI instead. And on the basis of the evidence here, this is very important. Two of the 7 metrics of ideal cardiovascular health also include physical activity and a healthy diet score. Now, once those 7 criteria are identified, what do you think is the percentage of the population in Canada, US, or in Europe who is in ideal cardiovascular health? Is it 5%? Is it 10%? 15%? What do you think? 5? 2? It's 0.1%. 1 out of every 1,000 individuals. The 2 hardest goals to reach, obviously, physical activity, salt content of the diet, and consumption of sugar-sweetened beverages. This is why only 1 out of 1,000 individuals is meeting the criteria of ideal cardiovascular health. Now, once these studies came out in the literature that it was a dismal proportion of the population in ideal cardiovascular health, they looked at the relationship between the absence of ideal levels with the risk of cardiovascular events. This is from the ERIC study, 20-year follow-up. And what you see here is the reference group. There were so few individuals with 7 criteria that the reference group here include those who have 6 or 7 criteria of ideal cardiovascular health, relative risk established at 1. Now, what you see here is the absence of optimal level of the biological risk factor. So elevated cholesterol, elevated blood pressure, diabetes is associated with more than a 10-fold increased risk of cardiovascular disease. No surprise to you. But the absence of optimal level of the health behaviors is also associated with a 10-fold increased risk of cardiovascular disease. And obviously, the combination of the biological risk factor and the behavior is associated with this huge, stunning increased risk of cardiovascular disease. All the studies that have dissected out the contribution of The health behaviors and the biological risk factor have reached similar figures. You can find several of those figures now in the published literature. But they do convey a very important message. To optimally prevent cardiovascular disease, it is as important, if not more, to target the health behaviors than the biological risk factor. This is not a trivial message to convey to the population. Now, as Ian pointed out, my interest for more than 25 years now has been to answer very complicated, complex, call it, use the qualifier that you like, what is obesity? And we know that on the basis of many population studies, it has been defined on the basis of the body mass index because many studies, this is the European Prospective Investigation into Cancer study, the EPIC study, showing you the J-shaped curve relationship between the body mass index and, in this case, the mortality risk. And you can see the lowest risk is in the ballpark of 25 in men and 24 in women. And we have many studies like this now. However, this is good to describe populations around the world. Cutoff might be different in the lower in the Asian population. But I was stunned when I started metabolic investigation 27 years ago. We could run studies where we could have individuals obese to the same extent, all having the same BMI, 30. Some of them would be metabolically normal, and others would have hypertension, impaired glucose tolerance, type 2 diabetes, clinical signs of cardiovascular disease. So to describe population and the shift in the population in terms of increasing prevalence of overweight or obesity, BMI is fine. But to assess risk, I quickly realized that we needed to go beyond that. And it's always a time in my talk where I pay tribute to previous investigators. Jean Vague was the first in 1947 to suggest that body shape matter. He referred to this condition here as android male-type obesity as the form of obesity more associated with diabetes, cardiovascular disease, hypertension, than what he referred to as gynoid or female-type obesity. But it took more than 35 years before two investigators, Ahmed Kiseba from the United States, from Milwaukee, and Per Björntorp from Gothenburg, Sweden, confirmed these early clinical observations with robust prospective observational studies. At that time also, there was a group of investigators, the Department of Internal Medicine at the University of Osaka in the mid-80s, who had suggested that we can measure precisely, actually, body fat distribution using imaging techniques. At that time, the technique which was used was computed tomography. And now we have seen many of those CT scans over the last 2 decades. And this is a very old slide. At the time, it was framed, you know, in a real slide, glass slide. That shows you how old I am. It's an old slide, and now it's a PowerPoint slide. But I selected those two individuals on purpose. You see, they have same age, same weight, same BMI, same amount of total body fat. The CT exam revealed that this subject here, you can see all the intra-abdominal or visceral fat in light gray, which includes the abdominal fat, retroperitoneal fat, mesenteric fat. So this subject has more than this subject here. This subject has impaired glucose tolerance, high triglyceride, low HDL, insulin resistance, inflammation. This one here is normal. But they have exactly, again, same age, same weight, same BMI. So we quickly came to the conclusion that's 25 years ago, that there was something else than the amount of total body fat. And just for those of you lacking sleep at night, if you want to read an abstract to put you to sleep, this is the first invited review that I published in 1990, after 4 or 5 years of publication suggesting that excess visceral fat was bad. And in that paper, we conclude that from the evidence available, we proposed at the time that subjects with excess visceral fat were those at the highest risk for cardiovascular disease. So this is a more recent update on the issue that I published in Circulation last September. I won't have time to go into details into the slide, but over the 25 years we have been interested by the environmental and genetic correlates, actually, of differences in the way we put on fat regionally. And one thing that we are convinced now is that when you have excess visceral fat, you are characterized by what I call a minestrone soup of pro-inflammatory abnormalities associated with insulin resistance, with an atherogenic dyslipidemic state, which will substantially increase not only your risk of type 2 diabetes, but your risk of cardiovascular disease. Other groups have used different names to characterize this minestrone soup, but the bottom line, and my point today, it is not associated with excess body fat per se. It is associated with excess visceral fat, but there's not necessarily a causal relationship. This is a marker of what we're going to describe as ectopic fat deposition. Now, in the mid-90s, we had access to a prospective study of middle-aged men that we followed at the Quebec Heart and Lung Institute. And we published evidence that some of those abnormalities that we saw among individuals putting on excess visceral fat, in that case here, is fasting hyperinsulinemia, elevated ApoB, and small LDL particles. That combination, and we published that in the JAMA in 1998, compared to men having none of those abnormalities, was associated with a 20-fold increased risk of ischemic heart disease. Now, we didn't publish that in the literature to suggest that from now on we should measure insulin, ApoB, and LDL particle size. That was just to provide evidence that those features of the minestrone soup are clearly associated with an increased risk of coronary heart disease. My major conflict of interest published in 2001 that there was a relationship between this popular inflammation marker, C-reactive protein concentration, and visceral adiposity. And actually, Isabelle reported that waist circumference was by far the #1 correlate of individual differences in C-reactive protein concentration. There are other factors, of course, associated with variation in CRP, but abdominal fat accumulation is clearly the #1 correlate. And now we know that this is due to the fact that in excess, once someone has excess visceral fat accumulation, the expanded visceral depot is loaded with inflammatory macrophages, creating a pro-inflammatory milieu, which will exacerbate not only the local insulin resistance state, but the systemic inflammatory profile. So on that basis, to make a long story short, you know, there's been this whole discussion about metabolic syndrome. Is this notion relevant to clinical practice? You know, our proposal in this paper that we published in Nature in 2006 was we cannot discuss metabolic syndrome in isolation. This is, otherwise we're misleading the population in terms of educating them about the key driver of this constellation of metabolic abnormalities that we are referring to as the metabolic syndrome. By far, abdominal obesity is the most prevalent form of it. There are more rare forms of the metabolic syndrome, but clearly this is the more prevalent form. Now, we never met to suggest, however, that there was a causal relationship between excess visceral fat and the metabolic abnormalities. Maybe excess visceral fat is just a marker of more primary abnormalities also associated with complications. For instance, if you had Sam Klein on this podium here, and Dr. McGavock, actually from Winnipeg, has published very nice data showing that liver fat, actually, excess liver fat accumulation, is closely related to all the abnormalities that I have described so far to be related to excess visceral fat. Now, there are several imaging studies now conducted worldwide that are trying to decipher the respective contribution of the various ectopic fat depot. With some colleagues, as well as with my good friend Bob Ross, we had the opportunity in a large international study to look at the relationship between liver fat, visceral fat, and cardiometabolic outcome in an international study on more than 4,000 individuals from 29 countries. Again, we measure abdominal fat by computed tomography using well-established procedure, and we use CT as well with the help of and at the guidance of Bob to measure liver density. And here you have a bright, lean liver, high density, high ounce fill unit, and here you have a darker, fatty liver with lower density, lower ounce fill unit. So keep in mind, the lower the ounce fill unit, the greater the liver fat content. And when we look at the relationship between visceral adiposity and liver fat content, you can see we found a very strong and robust relationship. And we're not the only one that have reported this relationship. In the Dallas Heart Study, for instance, they found the same thing. And you can see that when you look at those individuals, because they all had an oral glucose tolerance test, you look at those who had the normal glucose tolerance test, impaired glucose tolerance, or type 2 diabetes, they clearly are a distinct cluster. So type 2 diabetes is characterized on average by much greater accumulation of liver fat and visceral fat. So type 2 diabetes is not related to obesity per se, but to excess visceral fat and excess liver fat. And indeed, when we look at prevalence odds ratio for type 2 diabetes, in men and in women, we found visceral fat, one standard deviation increase in visceral fat to be associated with diabetes in men and women, no surprise. One standard deviation increase in liver density associated with a reduced risk of diabetes. No surprise, we expected that. But look at the relationship with subcutaneous adipose tissue. No relationship in men, and a negative relationship in women. Now, you might argue this is cross-sectional data. We did also prospective analysis with 3-year follow-up on 200 incident cases of type 2 diabetes. We found exactly the same thing. Visceral fat, liver fat predict an increased risk of diabetes. Subcutaneous abdominal fat is protective. Protective. So to sum that up, now when we look at the cardiometabolic risk associated with excess fatness, we propose that those visceral fat depots are actually associated with the cardiometabolic risk abnormalities that we had in the past associated with excess fatness. So we propose that excess visceral fat is closely related, is a good marker of excess liver fat. There's plenty of data now showing an association between EP pericardial fat and cardiometabolic risk outcome. Well, this is strongly correlated with visceral fat as well. Skeletal muscle fat is also related to visceral fat. Perivascular fat is also related, and even renal sinus fat, which is a tiny, tiny ectopic fat depot, is related to the other ectopic fat depot and independently associated with hypertension. I got to tell you, if I was a young PhD student, now with the imaging tools that are available, magnetic resonance imaging, it's a very, very exciting period to now better understand what are the independent contribution of all those ectopic fat depots. And my suggestion to the young trainees, don't get focused on a single one. Don't select your pet ectopic fat depot. They are all interrelated. The challenge now is to understand what are their respective role. And probably depending upon the clinical outcome, the relative weight might differ. But this will be a very fertile area of investigations for the next decade. Now, some of you may know that in 1994, we published this paper where we first suggested that on top of BMI, you should measure waist circumference to actually help you out in identifying those who would have more abdominal fat for a given BMI. But this paper actually was miscited a lot. And some people suggested that we had proposed to throw away the BMI and replace it by waist. This would be a big mistake, and let me tell you why. I had the opportunity to address this issue in an editorial that I published in the JACC last year. What you have here is the relationship between BMI and waist circumference in a sample of 60,000 individuals. And of course, there is a very robust relationship between waist and BMI, and that's why some investigators have suggested, you know, it's the same thing, why bother? Correlation is 0.85. It's true when you look at those individuals from very lean to very obese. However, here the box and whisker plot shows you the 10th percentile, 25th percentile, the median, 75th percentile, and 90th percentile. So you can see that despite the fact that there's this very robust relationship within a single BMI unit, and within every single BMI unit on that slide, you have more than 2,000 individuals. There's substantial individual variation. So you see, you should not delete BMI because you could have here an individual who is in the 10th percentile for waist circumference for a given BMI, whereas here would be 90th percentile because he has a lower BMI. An image now to explain this. Look at those two individuals. Two large waistline, two different phenotypes, two different risks. You see here you're dealing with someone with a very low BMI, low muscle mass. Here definitely you're dealing with different individuals. So if you use waist in isolation, you won't be able to distinguish those two phenotypes properly. With BMI, you will. And this is what is shown here. This is one of the studies that we have looked where we'll look at the risk of diabetes, the prevalence of diabetes within the BMI categories. And you can clearly see that if you look at the waist circumference tertile, higher the waistline within the BMI category, the greater is the prevalence of diabetes. Now, if you go back actually to studies where the relationship between waist circumference has been adjusted for concomitant variation in BMI with mortality. This is in the EPIC study, 360,000 individuals. Look at the very, very straightforward relationship between waist circumference and mortality. It's not a J-shaped curve. It's a linear relationship. There's still, however, a problem that we had with waist circumference in isolation. You could have here, you see this patient has a BMI of 55, very large waist circumference because she's obese, but she has a lot of subcutaneous fat, but she has very, very little visceral fat, actually. So there are some large waistline where this will be the result of excess subcutaneous fat accumulation. And again, this is the work of Isabelle Lemieux in my lab. To make a long story short, we thought, okay, large waistline, if we add to this a very close correlate of excess visceral fat, liver fat, triglyceride concentration. The more liver fat you have, the greater will be your triglyceride levels. Maybe you would be able to better discriminate those who are subcutaneous from viscerally obese. And to make a long story short, she did sensitivity, specificity analysis, which revealed that that combination in men, 90 centimeters and 2 millimoles for triglyceride, is associated with a fairly high probability that the individual in front of you has too much visceral ectopic fat, whereas that combination was associated with a low probability of being characterized by excess visceral fat, ectopic fat. Sensitivity, specificity analysis gave us 85 centimeter in women and 1.5 millimoles of fasting triglyceride. Now, when we put that in the literature, we just asked our colleagues around the world to validate whether we're wrong or right, and we got some help from some friends here. This is the Cambridge group, Nick Warham and Katie Carr, gave us access to their cohort of EPIC Norfolk, fairly significant number of subjects. You see 22,000 subjects, almost 10,000 men, more than 12,000 women followed for 8 years. Very robust, a lot of statistical powers. You can see a little less than 1,400 cases of coronary heart disease. We look at baseline at those having hypertriglyceridemic waist compared to those not having hypertriglyceridemic waist. Those are men. Look at the difference in blood pressure, HDL cholesterol, CRP, LDL particle size, and ApoB. Women now without hypertriglyceridemic waist, look at the very robust difference in blood pressure, HDL cholesterol, CRP, particle size, ApoB, just with the tape measurement and fasting triglyceride. I'm not suggesting to you tonight that this is the way to address the metabolic syndrome. Some people have miscited us again. No, just a cheap and quick way to at least focus, identify those individuals who are more likely to have too much fat stored at the wrong place. And when we look at Kaplan-Meier curve, this is the probability of remaining free from coronary heart disease in men not having hypertriglyceridemic waist, in men having either a large waist or large or elevated triglyceride in isolation, and these are the men with hypertriglyceridemic waist. You can see the difference is pretty robust. Same thing in women, women without hypertriglyceridemic waist, women with hypertriglyceridemic waist. Now, obviously, a fairly large proportion of our viscerally obese patients, unfortunately, are sedentary. And with the group of Cambridge, we have been able to, they have used very simple standardized physical activity questionnaire to classify their population. And I think this slide conveys a very, very important message. What you have here is the risk of coronary heart disease associated with being abdominally obese and have features of the metabolic syndrome in men and in women compared to men and women being not abdominally obese and not having the metabolic syndrome. And this is exactly what you would predict from the large published literature on this issue. Abdominal obesity, metabolic syndrome associated with an increased risk of coronary heart disease. Now, from the basis of very simple question, they were classified into very inactive to very active. Look at those individuals here who reported to be very active, who were abdominally obese, who had the criteria of the metabolic syndrome. Look at the reduction in risk of coronary heart disease. Don't you think this would be important to say to our patient who are abdominally obese, sedentary, with the feature of the metabolic syndrome, coming back to you, doc, I'm brisk walking, but I'm not losing weight. Well, you will do good in terms of your risk of coronary heart disease anyway. So even in the absence of any reduction in the waistline here, you're reducing risk of coronary heart disease. Now, tomorrow with Bob, we are going to have a debate on what to target, obesity or physical activity to reduce risk of cardiovascular disease. I'd just like to finish with a couple of slides where we intervene here in a group of viscerally obese men where we just improve the quality of the diet and we ask them to perform 160 minutes of moderate intensity exercise per week, not for 1 year, not for 2 years, for 3 years. And you can see they lost variable amount of visceral fat, but I would say 85% of them lost from a little to quite a bit of visceral fat. And at the bottom here, you probably can see that from the back. You'll have to trust me. You have the corresponding changes in body weight. And actually, it was stunning to us that some of our greatest losers in visceral fat actually gained 0.3 kilos after 3 years. So if your focus is weight loss, that poor patient listened to you, is now more fit, he has almost normalized his visceral fat, but he has gained 0.3 kilo. How do we pick that up? Obviously from the 6-7 centimeter reduction in waist circumference. And just a couple of cases in closing to show you here that individual BMI of 33, after 1 year BMI of 31 is still obese. He has completely normalized his visceral fat. We're doing a study now in post-coronary artery bypass graft patient with type 2 diabetes. Very sick patient, operated for the coronary heart disease, poorly conditioned. We do the same thing and we thought, well, if we get 50% of the response, we'll be happy anyway. We get the same thing. Progressive change, improvement in nutritional quality, no heroic effort in terms of changing their diet. Eventually, they are able to perform 160 minutes of moderate physical activity exercise per week. They drop their visceral fat, and look at, you don't need to be an expert to see that this patient here had a lot of epipericardial fat, and look at the huge mobilization of epipericardial fat. That study is currently on our way in our center. So in closing, coming back to this question, what is obesity? I guess we should let me suggest that we should refer to obesities rather than obesity. I don't think this is a monolithic group for sure. There are some rare genetic form of massive obesity. There are more prevalent polygenic form interacting with the environment. There's a lot of studies now coming out looking at obesity, SNPs, looking at genetic susceptibility. You just heard from Dr. Taylor, this is an important emerging issue, this drug-induced obesity, obviously childhood pediatric obesity, severe obesity, and a lot of attention is given to this 1 million individuals with severe obesity in Canada. That group is expanding. This is a sort of concern, but this is clearly a distinct phenotype from what I've discussed tonight. So I don't pretend tonight that I'm coming up with, okay, what is obesity? This is the answer. Not at all. I humbly suggest to you that this prevalent group of overweight, from 25 to 35-ish kilogram per meter square, the magnitude of deposition of visceral ectopic fat really determines the magnitude of the complication. I think we need to pay attention also to the frail, underweight elderly with the so-called normal BMI. And again, this is not meant to be an exhaustive list at all. So I hope that the message that I've conveyed tonight has convinced you that those ectopic fat depots, they really deserve attention. They are associated with excess visceral fat. We want to move from weight, and don't get me wrong, weight loss is okay as an outcome, but even in the absence of major weight loss, if you improve the behavior of patients of becoming physically active, you improve nutritional quality, you might get substantial reduction in waist circumference, the triglyceride will go down, and if you improve cardiovascular fitness, you might have done quite a bit for your moderately obese, overweight patient. Ian was kind enough to refer to our website, myhealthywaist.org. We're proud to say now that it is visited by 135 countries. As he said, feel free to download whichever material of interest to you. This is for free. Last July, we organized in Quebec the 3rd International Congress on Abdominal Obesity. We had 600 participants from 50 countries. The next one will be in Seoul next September. The deadline for submitting abstracts for those of you interested by this topic is May 17. Once again, thank you very much for your patient attention. And again, I accept this prize on behalf of my colleagues and students. Thank you.